this is this talk about hormones I've done for this conference a couple times since 2011. The first time I did it was with Dane Law and with Henry Malice. I don't know if you guys know either of those two people, but they're dear to me. And in all those years, since 2011, I've seen so many more patients and gotten so much more feedback, and there's some new research out there. So some of that we can actually incorporate in this talk. You can go to the next slide. Yeah, that's just a kill joke. It does really well when I present this to healthcare providers, is because, I think it's important for them to get the concept a little bit. So we'll talk a little bit about some of the aspects of medical transition. We talked about hormone therapy. We talked about the different kinds. A little bit of primary care that comes with that when you come to the doctor's office that may not all hormone prescribers do for you, but I do typically at my clinic. And we have some resources if we do questions. So next, please. Okay, so what do we want to achieve with hormone therapy? So I don't know if you all know, but there is a World Professional Association for Transgender Health that originated in the 1970s and was started by Henry Benjamin. And he and a group of psychiatrists started building these standards of care. In 2005, that organization was officially called the World Professional Association for Transgender Health, and these standards of care have evolved into Standards of Care 7, written down in 2011, and the Standards of Care 8 are being written as we speak. And these are all the guidelines for hormone therapy that are used by WPATH, but also the European Society, and by hopefully all the primary care providers prescribing hormone therapy in this country. And this organization is right now doing an educational initiative for all healthcare providers in the United States. They do trainings at least 4 times a year in the United States. So if you all see a different hormone prescriber, make sure they have heard of WPATH and they follow the standards of care as per WPATH. And maybe it would be nice if they've gone to those educational conferences. They just came out with their first ever certification plan, program, and certification exam, and I just took that exam 3 weeks ago to be grandfathered in as becoming a certified WPATH hormone prescriber. And I think that becomes important. I don't know if you guys were at my talk before, but talking about guinea pigs, you don't want to be a guinea pig. You want to go to somebody that knows what these standards of care are, what hormones are safe for you to take, and what has worked for others. And it's important to know that as you proceed or start with your transition. What I started doing in 2011 as well is I go by informed consent. You do not need to come to me with a letter from a therapist and say, here you go, my therapist now has diagnosed me with gender dysphoria and now I can start hormone therapy. That used to be a gatekeeping rule before 2011, but some healthcare providers may still ask you for that, and it's not appropriate. Because you should be able to just come to your doctor and say, I'm transgender, I want hormones. And then we go over all the risks and benefits, and we go over this whole informed consent model and thing, and you sign it, I sign it, you get a copy. But it's a nice little summary of all these things these hormones do for you, and hopefully these are all things you want to do, right? And it's not something that is new to you, because all of you are so well educated when you come to the doctor's office, because you've studied this online for years. So it's something that, that informed consent model works really well. Does it work for kids? Well, I know all of you are mostly above 14, but I do get parents with young kids to my clinic, and for some of them, they haven't quite figured out where they belong in the infinity of gender. So it would help to have a therapist to help them figure out where that place is and if that's truly something they want to do. And then also, I believe mental health care is very important to help with your anxiety, depression, bipolar disorder. I mean, all these other mental issues that play a role when you come to the doctor's office to transition. Because it's hormones will help with your gender dysphoria, but it's not going to solve all your problems and your depression and your anxiety and everything else. It may make it worse. So that's why it's good to see a therapist in conjunction with a hormone therapist. And if you come to my clinic, you get a big list of all these possible LGBT-friendly mental health care therapists you could choose to go see. But it's your option, unless I really tell you, yeah, you should probably go do this, but I'm not that paternalistic. I typically don't do that. So you still do need that letter for surgery. that is still gatekeeping. If you want top surgery, you need 1 letter. You want bottom surgery, you need 2 letters. If you want a hysterectomy, you need 2 letters. And those are still standards of care by the WPATH, Standard of Care 7 from 2011. And a lot of insurance companies abide by that. So they recommend that you have those 2 letters that they will not cover your surgery. Hopefully in the new standards of care, one of those letters will be gone, and I can write one of those letters, or your hormone prescriber, or your primary care, maybe 1 mental health care provider. But 2 mental health care providers is truly ridiculous, because you've maybe worked with 1, you never work with the other. So I can give you a name of a counselor that will say, okay, 2 sessions, I'll get my 2nd letter. All right, we all know the game, here you go. You know, and it's not how it should be, it's kind of silly. Okay, so these standards of care are continuing to be renewed because we're starting to see some research happening in transgender healthcare. It's a very exciting time in medicine for trans health because the academic centers are catching on and they have more time and money for research and they can study data and they are starting to slowly write little papers about the risks and benefits of hormone therapy. You know, the sad thing is these are articles written about 10 people over 2 years, so we don't have a lot of long-term data on large groups of patients. But in time that will come, and when you come to my office and you come for your blood pressure check and your labs and you're filling in this mental health care paper for me, and that's all data that one day maybe a researcher will have time for to study, and then we can find all this awesome information that we're looking for. But right now we don't have tons of it, so it is starting to come, and as you come to my clinic, or hopefully your other doctor's clinic, they will be up to date on this new research and can fill you in and like, oh yeah, hey, we figured this out, or hey, this is new. Oh yeah, we know now that, say, progesterone helps with making nipples look better and more poofy, and yeah, why don't you start progesterone? Because it's now proven to actually do something. And before we only thought, well, maybe it will do something, we didn't know. Okay, let's go to next. So what do you do when, so the mental health care really is kind of gone, but it's still an important part of medicine because like I was telling in there, 70% of the time you spend at my office is about, well, how are you doing? What's your support system? And are you dealing with seasonal depression? And, and a lot of you have anxiety and depression. 70% of people in transition struggle with mental health care issues, and most of them anxiety and depression. So that is an important part that any primary care doctor or hormone doctor should also address. So we're going to go to your medical history, and then with the next slide we'll have that too. We go by your family history, personal history, and it's important. And then, I do get a lot of patients coming to my office. They've already been on hormones. They bought them off the internet, or they got them from a friend, or they stole their mom's birth control pills, or they bought them from Mexico, or, and again, that I don't care. I mean, we're not there to judge people. We are just there to make sure you have a safe transition. And we also want to help you to help you with all aspects of transition. So not just here's hormones, why you can go and we'll call you with your labs, but it's important that all aspects of your life are working so that you have a good transition. So that is something you come to the doctor for, not just hormones. So if you're self-medicating, think about the things that may be beneficial for you as well when you come to the doctor and say, oh yeah, when was my last physical? When was the last time I had my shots? What else do I need for myself to make sure I'm healthy? So those are all good reasons to not just have a hormone prescriber for, but also get some medical care and some of the preventive care that you need that you have not been getting. Get the next. So yeah, these are things we go over. So it's important to find out, hey, what are you taking? What are you on? Are you doing drugs? Are you doing substances? Are you doing over-the-counter herbal things? All those things are important for us to make sure that the hormones we prescribe here are safe to use, right? So, and that includes a history of substance abuse. I know that sometimes y'all are not honest to me, and I find out because of a drug screen or because I get a call from uni that somebody tried to overdose on Klonopin or something else. And, but it is really important to be honest to your healthcare providers, and they should not judge you. So if you feel judged, you got to go find somebody else. But you should be able to honestly say, well, I've been struggling with my gender dysphoria, and just like Buck was saying, I'm drinking too much alcohol, and that's bad for my liver, and if you give you estrogens, it's also bad for your liver in combination. So there are reasons why we'd like to know if there's something you're struggling with, but also, hey, if you want to get sober, you want to get better, we have resources for you. I actually have a trans man right now in the community that's gathering a load of resources for me to give you when you come to my office. And it's anything from homelessness to, sober living, to all these possible things that I don't have access to that somebody else is getting for me to give you. And it includes counselors that are willing to donate a couple hours of free time to you if you don't have a therapist, but you need a crisis counselor. So those are all good things that, you can get when you come to a doctor's office. And be honest, and tell us about your family, because it's important to know if your family had breast cancer or other gynecological issues, if there was a lot of psychiatric issues, if there are diseases that start at a later age, if there's a breast cancer gene. I mean, all those kind of things are important to know for us when we start prescribing your hormones. Tobacco interferes with estrogen, so if you try to transition to a female and you smoke, you're killing yourself. You're undoing what we're trying to do for you at the office. And again, we don't judge you. We know how hard it is to quit smoking, but you could help yourself by not smoking because you would transition so much better and so much easier. You would need so much estrogen. Plus, you have a really high risk of blood clots that way. So there's a couple of things that we discuss with you, not just because we're paternalistic and smoking is bad for you, but also because we want your transition to succeed and it will get better if you don't smoke. So there are many reasons why we keep talking about Chantix and patches and gum and all that stuff, but address it to us because it's important that we discuss it with you, and there's some options to quit smoking. I know it's hard. Sexual history, it's important because hormones impact your sexual functioning. Both directions. Testosterone makes you horny, and estrogens come in, and testosterone blockers are going to stop you from having erections. So those are the normal functioning of the body is going to change when we put you on hormones. So where are you at with your sexual functioning? Are you happy with your body? Can you orgasm? Do you self-pleasure? I mean, do you have a partner? What do you guys do together? What partners do you have? I know we don't always talk about it so much at my office because there's a time constraint, but it's still important to bring up if you want to know. And it's important to know the effects of hormones on your sexual function. Labs, labs are an important part in these standards of care because the hormones can impact certain body organs, especially the liver, blood sugar, other hormones, and things like that. And then we go over the consent form, and we sign it, we give you a copy, and that's it. Next slide. And these are some of the things to keep in mind because we don't know long-term data when it comes to your cardiovascular health. What we do predict is testosterone will probably, over a long course of time, make you at increased risk for cardiovascular issues like atherosclerosis. Why? Because it makes your good cholesterol go down and your bad cholesterol go up. It makes your blood pressure go up. Those are things I've seen in many of my patients over time. So it's important to discuss it when you start hormone therapy and also assess where are you now at this point. I had a patient come to me this morning, they're like, oh, we're on estrogen, but we were just diagnosed with a heart valve problem, and is that a big issue? Well, as you know, estrogen can cause blood clots, and heart valve issues can increase the risk for blood clots. But this person was already on blood thinners, so no, it's okay. You can be on estrogen, it's safe. But don't let another doctor tell you it's not safe, because a lot of other doctors don't really know the ins and outs of hormone therapy, and they maybe advise you something that's not true. So then you just need to tell me calmly or something. Again, lipids and blood pressure. I do see that trans women on testosterone blockers generally, their blood pressure drops down a little bit, and that's because we give you spironolactone, and spironolactone is a testosterone blocker, but also a diuretic, so it makes you pee a lot, so it decreases edema in the body, so it makes your blood pressure go down a little bit. I also think it relieves a little bit of anxiety, and it makes you a little bit more calm, and that brings your blood pressure, especially at the office, down a little bit as well. Osteoporosis, we have no data. We don't know over a long period of time what your bones are going to do, if they're going to be healthy or not. We know in Utah, most Utahns are low on vitamin D, and you've probably all heard it from me, because I prescribe vitamin D to everybody that walks in my door, because that's important to keep your bones healthy. That with calcium, and calcium you best get from food. It's better not to take a supplement, it's better to drink milk products and cheese and fortified orange juice, and if nothing works, 2 Tums a day. Tums have a load of calcium in it, so that will help as well. So calcium, vitamin D, weight-bearing exercises. Exercise is important in your transition. It's important to work out, do some weight-bearing exercise. It helps prevent bone density. There are exercise workers out there that train old people, I mean people over 80, and they give them weightlifting. And it shows that after they've been lifting weights for 3 months, they walk upright, they have less muscular pain, they run out of bed quicker, they go up and down the stairs faster. So weight-bearing exercise is always important in your whole life, not just for your transition. A pituitary tumor can happen when you go on estrogen and spironolactone in that first year. Some women get a little bit of breast milk discharge, and it is normal. It typically goes away. But in those women who continue to lactate on hormones, there may be something that we should look into, because you can actually grow a benign tumor on your pituitary gland that can interfere with your transition if it gets too big. If it gets so big, it's going to push on your optic nerves, and you're going to have weird vision because half of your field is falling away. So that's a sign of a really big pituitary tumor. Fortunately, I've never had that in any of my trans patients. So there's of course other risk factors, but we can go into that for a long time. Polycystic ovarian syndrome. This is a syndrome where your insulin doesn't work very well. And what it does, it makes your whole body's household, as a born female, switch a little bit towards that of a male, and it causes overly hair growth. It can cause obesity. It can make your periods irregular. It causes all kinds of yuck, you know. But it's known that 50% of trans men have that condition. Why? Nobody knows. You know, it's 10% of cis women, but 50% of trans men. So there's got to be something there that has an endocrine explanation for why you're born transgender, what happens in that second trimester in your mom's uterus. We don't know, but there may be a link with that disorder, but time will tell and research will tell too. And that's the same connected to diabetes and metabolic syndrome. People that are overweight, your fat cells hold on to estrogen. That is nice for somebody trying to feminize, but if you're trying to masculinize, that fat's in your way because it holds on to estrogen, and it's harder to masculinize and get that six-pack and work and get that kind of square body that you're looking for, because again, finding that estrogen is hard. So eating protein, working out, another reason to work out. Polycythemia is thickness of the blood caused by testosterone. It can make your blood super thick. Actually, your hematocrit, which is the red blood cell count in your blood, so your blood's made out of red blood cells and fluid. And the fluid is what you all go do plasma donation for. So I tell my trans men, don't do plasma donations because you take the fluid away from the red blood cells, and the red blood cells are already high, so your blood just gets thicker, and it causes headaches and joint pains, and again, you feel yuck, red, bright red face, and you just don't feel well. So drinking lots of fluids, don't donate plasma or whole blood. And for some people, we have to actually send them to the hospital to have blood taken out of their body every month so that their hematocrit doesn't get too high. And for some people, we need to drop the dose of testosterone down a little bit so that their iron level is stable. Doesn't matter for transgender women. Okay. All right, a whole bunch of stuff. Testosterone is mainly injected. It is still the best way of doing it. Fortunately, in Europe, they have a depot testosterone that works for 3 months. If I could prescribe it to all my trans men, we wouldn't have any worries about fear of needles and being scared and all those kind of things. You just come to the doctor's office every 3 months and have a depot shot, just like for depot, Provera for birth control method. But it's not available. It's available, but it's not covered by insurance. It's super expensive. So therefore, we use testosterone cypionate. Generally, you can get it from any pharmacy. It's $10 a month. You can get it filled anywhere, and we teach you how to self-inject. It's a weekly shot. There is a standard dose for everybody. What we base it on your transition and on your levels. We don't want it to be too high, because if your testosterone levels run over the levels of any cisgender male compared to, you aromatize it into estrogen, and then your body holds on to more estrogen, and we just got your periods to stop, and now they start over again because you think more is better and you inject too much testosterone, but what it does is the opposite. So try to stick with the dose that you have been prescribed because there's a reason for it. And then depending on your levels, and you should ask your doctors what levels you have if you want to know. We generally just tell patients, oh, your labs are normal, but if you want to know, ask us, we would release it to you, because then you can see your levels and make sure you're in a normal range. Of course, it depends on when you've done your shot, because if you've done your shot the morning of your blood draw, it's going to be a little on the high side, and if it's right before your shot, then it's going to be a little on the low side. So it all depends. I have troches made up from the University Compounding Pharmacy. Jolly's makes it too. These are testosterone pills that you put under your tongue, preferably twice a day because they don't work so well. So you need to put a buttload of testosterone in it to make it work. I have to say, I think it works better for my patients that are non-binary and they're looking for a little bit of masculinization. So if your levels want to be, so normal levels for transgender men is 350 to about 1,000. It's the same as for cisgender men. People are non-binary that I sit with and talk to about what aspects of masculinization they desire. They generally have levels 150 to 250, which they're typically happy with. Those are levels that we achieve with these trophies. So they're a little more expensive. They're about 30 to 60 bucks a month. So it has to be worth it. You have to really super hate your jacket to be able to get the trophies. And then I prescribe gels and creams. Most people do fine with one packet. Some people need 2 packets, and it is expensive. So really only affordable if you have insurance that will cover it, and we're willing to fight with your insurance to see if they'll cover it. But if not, then you're probably still better off doing injections. Hormone pellets. These are little bioidentical tablets. They're a little bit bigger than a rice kernel, a little bit smaller than a Tic Tac. I ordered them from a compounding pharmacy in Colorado. They make them in Las Vegas too, but the Colorado ones seem to work better. And I place them in the fat of your butt, right? With testosterone, it works only about every 2 to 3 months. So it is kind of expensive, but it has worked really well for my patients with diabetes that have very brittle blood sugars that go like this. So if you do a pellet, it gives you a really nice, long, slow release of testosterone. You have to come every 2 to 3 months to have one inserted, and again, it's often not covered by insurance because it's compounded, and it's about 300 bucks every time you come in. But I have a few patients that prefer this way of doing testosterone because it helps the blood sugar stay stable. So it has been a better way for them to do it. It seems like if we put in more pellets, it works longer, but again, every pellet is about 40 bucks. So if you do 5 pellets, that's like already 200 bucks there. So it adds up. So fortunately for trans women, estrogen pellets last a whole lot longer. They last about 4 to 6 months, and you only need 2 at a time. So that's a lot more feasible for their transition than it's for a trans man's transition. Here's a little bit of what testosterone does and how long it takes. It's a nice little table to look at the things that you can anticipate. Typically within 3 months you come back and you feel mentally a lot better, you feel energetic, and you feel like your voice is squeaking a little bit, and you're sweating and the sweat's smelly, you get a little bit of body hair, and you get, you want to have sex more, and you may have a little increased anxiety. Those are the first things that I noticed 3 months when you come back for a follow-up. And over time, you'll see all these other things happening. Not all patients realize that your clitoris grows as well, and that's exciting for a lot of men. But I've had some teenagers come to me like, oh, what's going on? Something is not normal. I'm like, no, that is normal. That's what happens. It is typically something that stays. So if you stop testosterone, your clitoris kind of stays a little bit bigger. And I've seen that in some of my patients with an intersex condition called congenital adrenal hyperplasia, where their adrenal glands don't function right and they have too much testosterone in their body, and they're typically born with a large clitoris, and they come to me in their 30s and they're like, we don't want this big clitoris, we want it to be smaller, and you can make it smaller, but it doesn't shrink by not giving the body testosterone. Once it comes, it kind of stays. But for some trans men, it's never big enough because they would like to have a metoidoplasty, which is a procedure where you kind of release the clitoris and like make it drop down, maybe even build the urethra to it and make it function like a penis. But it will never be a really big penis, unfortunately. These other things happen. Vaginal atrophy, we just addressed in the keynote. That is an issue that we're dealing with, and there's no easy solutions yet, but we're working on it. Okay. Libido changes, yes, for most people. Okay. Then who should not be getting testosterone? I honestly give everybody testosterone. This is a condition where your blood's already thick, but again, with pheresis and some medications, you can keep it at bay, and you titrate the testosterone up safely so that people with already high hematocrit can still masculinize. Because remember, your hormones become your lifeline, so not to be able to be on your hormones, that's horrible for people, because it means you can't just transition. Well, you don't want to not be able to transition and have to stay in the body you have for the rest of your life. So that is not an option. So no matter what happens, we have to be able to make it work somehow. I've had patients with a history of breast cancer that were estrogen sensitive, whose oncologists are perfectly fine with you going on testosterone. So again, it should not be a reason not to go on testosterone, but there needs to be a conversation between doctors to make sure that we're all in the same boat. Uterine and endometrial cancer, it's typically not a problem. People who have that, they are begging me for a hysterectomy, so it's, generally, unless you want to have babies, but that's a whole different story. But so this is not really important. Active pregnancy, I've had people come to my office that were actively injecting testosterone and then found out they were pregnant. That can happen, and that's bad, because what can happen to the fetus, who knows? I haven't really seen an outcome of a trans man that's injected testosterone the whole pregnancy and had a girl fetus and looked to see if the baby is virilized, we call it, again, with a large clitoris and maybe some masculinizations, but hopefully I won't have to write that first case report, because that's not a good thing. So remember that, pregnancy can happen on testosterone. Kidney failure, I have a few patients with bad kidneys, and I work with their kidney doctors to make sure they can still transition safely, and they can. Thyroid disease, if your thyroid works too slow, you will not masculinize, no matter how much testosterone we put in your body. And it's important to regulate the thyroid before we give you testosterone. And I've had a few patients who we diagnosed with hypothyroidism just because they wouldn't masculinize. We're like, well, let's check a thyroid, and then it's off. And when you adjust the thyroid, then the testosterone works good. Again, testosterone can turn into estrogen. I have a lot of trans men that are really worried about hair loss on testosterone, and it is something that we cannot necessarily prevent, because a lot of that is genetic makeup, right? It doesn't seem that people on testosterone, like trans men, lose their hair more so than cisgender men. It just happens, and once you start testosterone, that's a risk that's going to happen. And the question, well, does it work to take finasteride and DHT block and all of that? Yeah, I've given some to my patients, but I don't know how much it interferes with your transition. We have no idea. There's no data on that. So I prescribe it, but again, I don't know if it really helps. Some of my patients use Rogaine. That may help too. I'd like some data on that. That'd be an awesome research study to do. So if anybody knows or has an idea, that'd be awesome. So this can happen. So I do tell my patients, yes, look at your uncles, your grandfathers, your dads, and see what happened there, and you may very well lose hair. And most men hate losing hair, but it's part of life, right? So again, obesity interferes with your transition. Of course, after we take your ovaries out as a trans man and you're on testosterone, we don't have long-term data on what's going to happen to your bones and your heart and your overall health. But on the other hand, cisgender men who have testicles that produce testosterone also don't have estrogen in their body. So, maybe those data are the same, maybe they're not. Again, vitamin D, calcium, weight-bearing exercise are important for all of you. Okay. All right, we go and switch over to trans women or feminizing medications. So in America, we use spironolactone, and spironolactone is a medication that we use for many different reasons, but especially for people with high blood pressure and some cardiac diseases. We use it for acne, but then here we use it for transgender healthcare, and it is because citron acetate and mercure, which they use all over the world except for the United States, is not approved in America. Why not? We don't know. It's an FDA thing. It's very political. The FDA just approved a super strong, crazy opioid medication in our current opioid crisis, and it's ridiculous. And yeah, I don't know. The FDA does crazy stuff sometimes. So we use spironolactone, which works, but it has some nasty side effects. I actually have one patient that we think got a cataract from it, but that's a fluke. So most of the time, spironolactone does okay. Your body gets used to it. You get used to peeing a lot. You get a little this brain fog people talk about, and they're not so much aware of it unless they've had a vaginoplasty and they don't need to take the spironolactone anymore, and they're like, oh my God, I feel so much better. Then that may have been due to the spironolactone. The finasteride works, or dutasteride, or there's a whole bunch of same medications in that same group. works, especially for people who've already had some male pattern balding, and it may help with some hair regrowth, like we were talking about as men. With as women, it works typically pretty well, but if you've lost your hair over a long period of time, that hair is not coming back with finasteride, no matter how much we give you. But if you're young and you just lost some hair, and especially here in the sides, a lot of that will grow back in on finasteride. EndoCure, unfortunately, works good, but it's not covered. It's also put in the Diana pill that's being prescribed to women in Europe with some over hair growth and PCOS, and it would have been a great option for lots of Americans if it was approved, but it's not. Okay. So estrogen also comes in many forms and ways, and generally we start out prescribing it as a pill. And an estrogen pill is called estradiol. It's not birth control, it's not pregnant horse urine hormone. It is pure synthetic estradiol, which has proven to be safer when it comes to risk of blood clots and some other side effects. And we give it to you in high dose. We start on 4 milligrams oral, so it's typically 2 pills, but I've titrated a lot of my patients up to even 8 milligrams, but that's if you're young and healthy and you don't smoke, because otherwise I'm worried about your risk of blood clot there. So at that point, oral estrogen only works for so many people because at some point it gets metabolized, and for people who are really skinny, it just doesn't seem to uptake in the body. And it doesn't matter if you put it on your tongue or if you just swallow it, it doesn't really seem to be a difference. So there may be a point where we recommend people to switch to injectables. And estradiol injectables are generally compounded by our university pharmacy, but recently have been available again to the regular pharmacies. It's estradiol valerates, either in 20 or 40 micrograms, and we have the 30 micrograms compounded for people that do not get to the pharmacy and get it covered. The compounded kind is a little bit more cheaper than the brand names from the pharmacies. The injectable is a standard dose you do every week, and we try to take that up depending on your levels and how you're feeling. But I generally see the overall levels to be a little bit higher than what's there on pills or patches or whatnot. Patches are expensive. I think they're a little bit safer for older people that are smoking, and for some of my patients, it's been a really good use, but they are expensive and they're not always covered by insurance, and you need to put 2 or 3 at the same time on. And if you get a generic, these are these big brown patches that you have to put on your body, and when you work out or shower, they tend to fall off. So it is not always the best solution. So generally, pills and shots work best, and then the hormone pellets, I've used those for a lot of my patients. They work really well too. You put them in every 4 to 6 months in your buttocks, 2 at a time, and they get your levels really nicely between 200 and 300, which is right where we like it to be. And a lot of my patients have absolutely loved that. Not just after an orchiectomy or vaginoplasty, but just to take less pills, or people that forget to take pills, or people at higher risk because they're older smokers, truck drivers, sedentary jobs. Those are people sometimes who say, well, pill probably makes you a bit high risk for blood clots, but this would probably be safer to do transdermal or indermal or something like that. I've only had 1 patient so far that I'm aware of that drew a clot from estrogen. She was over 40, a truck driver, and a smoker. So those are all risk factors for estrogen. And you have to understand, this is about over 2,200 patients I've given estrogen hormone replacement therapy to. So just to have 1 that I'm aware of is a pretty good number. So this is what happens in estrogen and testosterone blockers too. Your skin gets a little bit softer. You do get some breast growth. In about the first 3 months, you get some nipples that poof out. You have little tiny lumps that develop under the nipples, and I always tell my patients these are good lumps. They have to be there. They're not bad breast lumps, so let them grow. So and then you may have a little bit of nipple discharge from the stimulation of the breast tissue, and they hurt like half the first 3 months or so. It gets better, but they do hurt. So that's the typical first thing I see. And then for most people, it's the mental well-being. It's in 3 months people come back to you and they're like, oh my God, we feel so much happier. We feel like we're me. We look in the mirror, I see myself. Those are like things I hear over and over from people. So to say it's gender affirming, right? So of course your erections 1 week, they're gone. So be aware of that. That's why I'm for semen preservation before you start hormone therapy, because rectal functioning goes down quite a bit, your ejaculate disappears quite quickly. It turns clear and then it disappears, and then there is no more. There may be some here or there, but typically there is none. And I advocate at my clinic that my patients who I put on testosterone blockers, that they regularly masturbate. And this is why I tell people that it's because your sponge bodies atrophy and there's no blood going through them. And if you don't occasionally let that blood go through there and release itself, it kind of dries up to where you can get really painful erections. And there's not much else you can do about it, because if you're at the point where the sponge bodies have atrophied so much that they won't open up and the blood's trying to push itself through, then you hurt. And the only way at that point to make that go away is to either regularly masturbate to see if some of the function comes back, but for those that are very dysphoric about it, to think about having an orchiectomy or vaginoplasty. And I know it's easier said than done because there's all these rules and all this money and all this other stuff, but that is something that I recommend. And sterility, but it's not guaranteed. So remember, I had a patient 6 years on hormone blockers who made her partner pregnant, and that was not expected, but it can happen. And with Viagra, you can still have erections and still have penetrative sex. So if anybody ever would ask me, that's something I prescribe. It's important. Okay. Again, we've just talked about this. If I have patients that smoke, we talk about how to transition, but I know it's hard to quit. People with liver disease, oral estrogen processes through the liver. So if your liver tests are elevated, sometimes they're a little bit elevated. A couple people say, well, maybe lay off the alcohol and the Tylenol and see if it goes away. But for some people who really have a history of hepatitis C or drink significantly, probably not do oral estrogens, but dermal estrogens probably safe. Clotting disorders, I have a few people with a history of pulmonary embolism on blood thinners, and they're on estrogen. Because you should not be contraindications. And don't let these doctors at the hospital tell you you cannot be on estrogen. You can be on estrogen. So remember, it is also about your life and your quality of life, and not so much about only what's good for you, but it's also about being able to live your own authentic self and taking that risk that maybe you can have another blood clot. But who would you rather live as, and what would you rather do? And you should be able to be allowed to decide that for yourself and not be told, no, you can't have this, because it's important. It's your insulin to your diabetes. That's what your hormones are. Okay, next. Progesterone is very, not controversial, it's just that we have no data about it. There is a small study that shows that there is some increased nipple development, a little bit of breast development, and don't start it right away with the estrogen, started a little bit later because you get a better shape of breasts if you do progesterone later. Now, some of my patients love progesterone, others absolutely hate it. It is really truly an individual choice for people to go on it. You can take it for 10 days or 12 days or 14 days or all month long. You can take a low dose, you can take a high dose. There's natural progesterone, there's synthetic progesterone. I have a few patients that want to do depot progesterone every 3 months or every month. Some of that is your own transition, and you get to decide what you want to do, and then I get some feedback from you, and we can do it a little bit longer or try a different form, or you may absolutely hate it and not want it, and then you stop taking it and maybe start it up later, or stop it when you've had a breast augmentation. Those are like all individual choices for people. Again, just like in cis women, a lot of progesterone can cause weight gain. It's because it makes you hungry and it holds on to the calories. Gallbladder issues, yes, but that can happen with estrogen too, but I haven't seen it that much. That's why I can talk about it. Prostate cancer, man, I don't really see that. So studies are lacking. So we need some good studies, but progesterone is not a sexy medication to study, and there's no pharmaceutical that will support that, so there's no money for that right now. So maybe it will change since more and more academic centers are more interested in this, hopefully. Okay, so once you've had an orchiectomy or you've had a vaginoplasty, you don't need the androgen blockers anymore. I have a few patients that try to fight me over finasteride, and they believe it helps with keeping the hair on their head because of the dihydrotestosterone produced in the adrenal gland. I have seen it when people have had an orchiectomy or vaginoplasty. For about 3 months, they've seen an increase in hair development. And I think it's because the body is trying to find testosterone wherever it can. It's going to go to the adrenal gland and try to grab it and make it try to function with testosterone, but that typically goes away in time. So again, I tell my patients usually, don't worry, it goes away. You don't need to have any more blockers, because if I check the testosterone level, it's less than 3, that means there's none. You know, and then some of my patients need a little bit of testosterone after vaginoplasty or after an orchiectomy because of sex drive, because of fatigue, because of some of those issues, and then we can add back a little bit of testosterone. But that testosterone isn't necessarily going to make all your hair grow back, that you just spend loads of money on electrolysis on it. It won't do that. But it may be beneficial for some people. Removal of the ovaries for trans man is always a big discussion I have with all of them, because you can do a hysterectomy and not necessarily remove the ovaries. That is truly an individual choice. The only thing is, if you leave the ovaries, they just dangle on the side, you still need pelvic exams, you still can have ovarian cysts. These ovaries produce hormones. You can get ovarian cancer. It can interfere with masculinization. If patients have their ovaries removed, I see a better masculinization because some of that muffin top goes away, and it just tends to be that your face gets a little more square and less pink, and that may be some benefits for people who have a hard time masculinizing or have a lot of peripheral fat, because again, that holds on to estrogen. So your estrogen goes down quite a bit. Your testosterone does not need to be changed, you stay in the same levels. That actually is almost the same for trans women who've had an orchiectomy or vaginoplasty. I know most of these gender surgeons, they say, well, now you need to drop your dose significantly down and only be on this much of estrogen. That's not always true. I don't have any studies for you to prove that that's the case. So again, that's a case-by-case basis, and it depends on how old you are and where you're in your transition and who you love. And it has a lot of more other aspects in there. And the same with this. If you want biological children one day, but you don't have the money right now to have your eggs taken out and have them frozen and have them spend 10 grand to have them prepared for you, then you just keep them in your body, right? Until you know for a fact that you don't ever want to have biological kids, and or you'll never have the money or whatnot, you know, then we can take them out later on, you know. But be aware, you need pelvic exams because these things grow cancerous, right? So it's important to keep that in mind. Don't think you have my uterus out, I don't ever need to go to a gynecologist, I don't have a cervix, I don't need a pap smear. If you have ovaries, you still need a pelvic exam, so that's important. It's the same as when you've had top surgery. They leave a little bit of breast tissue in your chest because they sculpt it, so you still need your chest exam. Maybe every year or two, but you can still develop cancer from breast tissue that's left behind by your top surgery. So it's important. Some bills from the lab for those things, but it's not included in like a physical. So STD screening, you screen for HIV, hepatitis, syphilis, herpes. Some people want to know, some people don't want to know. It can be sexually transmitted, oral sex, you know, genital sex, and rectal sex. And then we screen swabs. We do throat swabs for chlamydia and gonorrhea because you can actually carry chlamydia on your throat, and most people don't know that, but we've had some positive throat swabs for chlamydia. So it'd be good to put that into your STD screening panel. Also do rectal swabs if you have anal sex, because you can have chlamydia in your rectum as well, and we found some positives there as well. So swab everything, urine check, blood work, vaginal for people who are not dysphoric, we do a vaginal swab, but you can do the same swab with urine. So it makes it a little bit better not to need a pelvic exam every time you do pelvics. You do STD screening because it's not required. Perhaps I already talked about that. It's very important. If you don't know who your partner's having sex with, you should consider HIV prophylaxis. It's available. It's often covered by insurance, and there are free clinics available in Salt Lake City. You can get that from. Contraception if you're having sex. If somebody with a uterus is having sex with somebody with a penis and semen, you could get pregnant, and it's important to use contraception. Sexual health is important. And again, ask for what you need, right? Don't have your doctor tell you what you need. It's important that you're aware of some of these things so that if they forget, they can do that for you. And not all doctors know this stuff because we don't really get taught in med school about this. You have to actually do some extra, show some extra interest and take some extra classes to know this stuff. So your physician may just not be aware that they should check these things every so often. So it's important to ask for what you need. It's important to talk to your physician about what bothers you, you know, even if it's something here that you're dysphoric about, talk about it. At least talk about it. An exam, yeah, maybe yes or no, but at least talk about it. And then, yeah, have a good relationship so you can talk to people, educate them. Again, this should be starting to disappear. There are so many there is a lot of trans health right now advocated through primary care, through the Endocrine Society. I mean, you can't open a magazine for the Endocrine Society, which is already endocrinologists, right? And they're getting training in trans health, so they're trying to really push these doctors to learn about transgender healthcare. So if your doctor says, well, I don't know anything about that, that usually means that they have no interest, because they would know something about it, because it's out there more so than it was in 2011 when I started, when there was nothing. So over the years, it's picking up really quickly, and a lot of young doctors are very open to this kind of help, to this healthcare, because it's new, there's so little known, they want to take care of you. If I teach my residents, students, or medical students up at the U, there's more and more of them are interested to listen. They stay and they want to hear these talks. So things are looking positive in the healthcare industry. So it's a good thing. All right. Next one. Yeah, insurance coverage is getting better over the last 2 years. I'm telling you. I mean, most things are getting covered. Surgeries are getting covered. Puberty blockers, I have to fight really hard with insurance companies to get that, but a lot of surgery is getting covered. And yeah, there's some stipulations and there are some co-insurances and deductibles you have to meet, but it is looking better than it was a few years ago. But just don't have Utah State insurance or Mormon Church insurance, because they still will not cover it. The Desert Mutual insurance is actively pulls every claim I sent them to make sure they see nothing about trans health in it, and if they see it, they will deny the claim. And nothing I can do about it. I've already called Utah and ACLU if there's something they can do, because it's discrimination, but they do it. So that insurance doesn't work very well, but most other insurance is working great. And they cover pap smears for trans men, so if you have a male gender marker, they'll cover pap smears. If you have a hysterectomy, you have a male gender marker, they generally start covering hysterectomies. So if you need a mammogram and you have a male gender marker, they start covering that. So things are looking better. To the health market, to Obamacare. Most like health and university healthcare they're trans inclusive. So if you don't have insurance, it would help to maybe look into options and see if there's maybe this year something out there for you, and the surgeries you've always wanted to maybe covered now. So it would help to look into that. And we always have an insurance agent that my office gives information out to. If you ever need any questions about insurance, he will help you get insurance, because he knows exactly which plans are trans-friendly. So talk to us if you have questions about that. To the next. Oh yeah, this is a quote that I stole from another trans man. This is nice. And I think the next one is just some resources. Yeah, these are good resources. So WPATH, they have a website where the standards of care are written. The Endocrine Society, stole their recommendations, and then the UCSF Transgender Health has an awesome website with anything you want to know about medical care for transgender people. It's good to know if you need to give some education to your own primary care doctor. There's good information there. There should be a reason that doctors can't find this information online, because it is out there. And then this is kind of where I used to get my information from when I started this, because there was nothing else online. I mean, they've been doing transgender healthcare for a long time. And then a lot of stuff on the internet, but be aware it's not always true. Everything written down, a lot of times is subjective. These are things that one person is saying, and it may not be generally true, so be aware of that. Or call us or come see us, doesn't matter. Okay, so I'll take questions.